to life in a completely different culture than he was used to. The cultural association helped him get started on his new life. My Uncle George would bring my father with him to the annual Summer Cultural Groups Festival, and later, he would bring me. It was incredible to see so many people of all ages laughing and celebrating with food and song and dance. It brought back the best feelings of home and gave my father the opportunity to pass his culture, language, and values on to me. My father and Uncle George were very close, so when George died last year, my father wanted to honor his wishes to be buried with a traditional ceremony back at his birthplace. My father told me that because Uncle George had cultural group life insurance, he was able to afford to bring George home and have the traditional burial George wanted. Though my father had been able to honor my Uncle George's wishes, it got me thinking about my own family. One day, I'd have to make the same arrangements for my own parents, and my wife's parents as well. Of course, we would want to bring them home and honor their wishes, but it would be a financial hardship for our family. There were a lot of things to think about, even though I really didn't want to think about them at all. When my father told me about cultural group life insurance, he told me it's intended to help families when they need it the most. It's not tied to an employer, so no matter where my career takes me, I'll always have coverage. The more people who participate and the younger they are, the more it helps keep the insurance premiums down for the entire association. Because my parents have cultural group term life insurance, there will be money available to help me provide the kind of service I want to give my parents. And by joining, I can put my mind at ease and continue to celebrate our traditions into the future. With cultural group life insurance, I can worry less and spend more of my time celebrating with the people who matter most to me.
As you know, my show is centered around health information, health education, and social justice that is affecting, or social issues that are affecting public health. So, as you know, today our topic is about COVID and COVID vaccine and ethics about COVID, around COVID vaccines. So before we start, I will come to introduce you my guest, but I also would like to talk to you about Bolus Body Butter. And as you know, many have enjoyed using Bolus Body Butter, and these are beautiful and nice scents from homemade raw shea butter and coconut butter with essential oils and vitamin E. The reason why I'm making those creams is that I liked making them for myself, but then my friends liked it, and I decided, because I have the non-profit organization Cellal Africa, cellal.com, CELLAL.org. So selling those body butters will help me fund the non-profit organization. So every cream that you buy, about 10% of the proceed will go towards Cellal, and that's for women and children's health in Africa. So yeah, thank you for those who are supporting, and those who want to do something, or buy, will provide you with a link. And today I am so honored and excited to be sitting here with some of the most respected doctors here in Minneapolis and around the country also. We have Dr. Gromesh next to me, and as you can see, we are respecting the social distancing. We have 6 feet away from each other. That's why we are not necessarily required to wear the mask when we are talking. So we are using the precautions, and some of us are already vaccinated. So here we have Dr. Gromesh, and next to her we have Dr. Rasmus, and then from Skype we have Dr. Eccles Radke. I'm so bad with it. Dr. Eccles Radke, hi. So I'm going to go around to have them introduce themselves, and you will go from there. Dr. Gromesh.
Yes, hi. Thank you for inviting me, Bolo. So my name is Beth Gromesh. I am a hospitalist at Methodist Hospital, and that is a suburb of St. Louis Park, or excuse me, of Minneapolis in St. Louis Park. So I went to residency training at Hennepin County Medical Center, where a lot of these colleagues are from. So I am an internist. I work in the hospital, and I see a lot of COVID patients. So that is a big part of my job, is to take care of patients that have been hospitalized for COVID. And unfortunately, that has been a lot of my life here this last year, taking care of COVID patients, but also working on treatment protocols for our hospital. The other thing I'll introduce about myself is that I was part of the AstraZeneca vaccine trial, and I have the opportunity to get the Pfizer vaccine next week. But because I was in the AstraZeneca trial, they unblinded me because that trial's not quite complete yet. And happy to report that I am fully vaccinated now, so I've had both vaccines, both injections from AstraZeneca. And we can talk more about that later.
Yay! Thank you so much, and welcome.
Thank you.
Dr. Rasmus, your turn.
Bolo, thanks so much for having me. I work at Hennepin County Medical Center with Bolo as well. I'm a psychiatrist, but I'm the kind of psychiatrist who wanders around the medical hospital helping out with mental health difficulties, stress, side effects to medicines, adjustment to being medically ill in the kinds of places where Bolo and Beth work. I also had the opportunity to train during part of my medical education at the National Institutes of Health. And while I was there learning about consultation psychiatry, like what I do, I was also taught about bioethics, some of the principles that go into the research that we all count on for the medical advances that keep us healthy. Understanding the history of where that came from was part of the coursework that I got to spend time with while I was there. And so now I'm on the ethics committee at Hennepin County and help to think about policies and making sure that our patients are safe regardless of the kind of care they're getting, whether it's old established care where we know all of the ins and outs and have all the details figured out, or whether it's a brand new disease like COVID where there's much that is unknown, including to doctors, not just to patients, and dealing with that uncertainty and making sure that we do the best that we can to stay safe as we try to figure out the answers to the questions that we all want to have, so that we'll all feel better and confident in the medicine that we receive as we go forward.
Thank you, Dr. Rasmus, and we truly appreciate your help at Hennepin in terms of helping with strong side effects and withdrawal to strong medications, psych meds, and in ethics too. Thank you so much and welcome.
Thank you, Paul.
And also at Hennepin, as you know, we have so many different kind of infections, not just COVID. We have infections from all around the world come to Hennepin because it's a safety net and it's a teaching hospital that cater to people from all around the world. So the doctors that are there in the infectious disease are very knowledgeable of any kind of disease or infection that you bring to the table. So one of them is Dr. Radke, I did it right. And welcome, Dr. Radke, and please introduce yourself.
Hi, thank you for having me here. This is amazing that you do this, and I'm so excited to learn more about it. I am, as you mentioned, an infectious disease physician at Hennepin County Medical Center, and pre-COVID, well, still, I take care of a whole number of different infections, and people from all over the world, come here with different things, both travelers and immigrants and refugees. But some of my other roles, in addition to taking care of patients, are that I'm the medical director for both infection prevention within the hospital and clinic systems, as well as the medical director for employee health and occupational wellness. So every time someone new starts to work at our hospital, they need to make sure they have the right vaccines and safety things in place, et cetera. And so I was doing that before COVID, and when COVID hit, it became really important that we needed to both protect our employees and our patients in the hospital and clinic settings. And so I very quickly became involved in the COVID work and response at the hospital, and have been serving as what was deemed the medical technical specialist on what we call our incident command team within the hospital system. And that's a team that is put together with people from literally all departments of the hospital, supply chain, the emergency room, the laboratory, doctors, nurses, cleaning, environmental services, multiple departments in the hospital, just to make sure we're all working together, we're coordinating, and we're having the right supplies coming in and everything. So it's really a pleasure, after all the work I've done with that during this year, to be here talking to you guys today about vaccines. It's a real beacon of hope looking forward with everything going on. So thank you.
Yes, thank you and welcome, and we appreciate all what you guys from Infectious Disease do at Hennepin in terms of helping us with recommendations and medications and things like that. So thank you. Welcome all of you. And Bethany also was planning to go to Senegal with me for my medical trips, and unfortunately, because of COVID, we had to postpone it. So hopefully we'll do it next year, because we are waiting for the vaccine.
Right.
So before any further delay, we're gonna move on to the topics. I know people are waiting and we don't have much time. So you said you just had your vaccine. It was can you tell us about it?
Yes.
The trial that you were involved in, AstraZeneca?
Right. So Health Partners here in Minneapolis area was part of the Oxford AstraZeneca COVID vaccine. This vaccine is a little bit different than the Pfizer and the Moderna one that have been emergency access approved. This one actually uses a cold virus called adenovirus that kind of takes the protein, the spike protein from the COVID virus itself, to kind of introduce it into the cells. So it's, like I said, it's a little bit different kind of science behind it. What's really exciting about this vaccine is that it, because of that technology, it likely is going to be one that is going to be available to global health and to countries that have less access to, like, the cold chain, because we hear a lot about Pfizer and how it needs the super cold technology to keep it in transport. So I have a lot of hope for this vaccine. The trial is not yet complete, so I was unblinded early, and I appreciate that they did that because I had opportunity to get another vaccine. It was very well tolerated. I had 2 injections, so there's 28 days apart. I really only experienced some mild body aches and some mild fatigue, and just a little bit of arm soreness, and really nothing that was significant. One day I did take ibuprofen, but that was about it. Certainly did not have fever and chills or any serious side effects, and it was a good experience.
Oh, wow. So the AstraZeneca is the one that will go globally,
Likely.
to third world countries, because the other ones that require deeper freezing cannot make it there.
Right. AstraZeneca's vaccine only needs refrigeration, so I think there is a lot of excitement and buzz because of that.
Okay. And I know that we'll get there, come back to that question, that a lot of Africans are afraid of the vaccine. So now here's a doctor who already took it.
Yes.
So they say, practice what you preach. So you took it and you're here.
Definitely.
Thank you.
Yes.
And so maybe we can send this question to Dr. Radke. Can you tell us a little bit, because just to refresh people's memories, and I'm sure some people may not know as much as the ones who are in the medical field, just a summary about COVID and the COVID signs and symptoms and transmission, and what precaution people are required to do.
Sure, I'm happy to. So COVID is at its base a respiratory disease, meaning it spreads through people's breathing, coughs, respiratory droplets, etc., which is why you see everyone needing to wear masks, because if everyone wears masks, the chance that we'll spread it to anyone else is incredibly low or acquire it. That's why it's so incredibly important when you're around people not in your family or household, or if people are being exposed to others, to really make sure and protect yourselves and protect each other by covering not just your mouth but your nose as well. And so that's really important. In terms of signs and symptoms, this is an interesting disease. It's different than ones we've seen in the past. So of course, the main things that you think about with a respiratory viral illness are things like fever and chills, cough, trouble breathing, chest pain, but some people will have symptoms as mild as sniffles and runny nose and sore throat that looks like strep. Some people have body aches as well that looks sort of like the flu. And interestingly, some people will have sort of stomach upset, diarrhea, nausea, things like that. And on rare occasion, people will have symptoms such as like skin findings, weird rashes, things like that. And the other interesting thing I think about this is it can cause people to lose their taste or their smell. And so if you find your smell or your taste just aren't working as well and you think you could have been exposed, make sure you put your mask on and go in and get tested. It's really important. And so I think that's why everyone hears about masking, hand washing, and social distancing as sort of the three big things we can do to keep each other and ourselves safe right now, so you're not getting too close to others and spreading things.
Thank you very much. That's a very understandable, at a level of non-medical people to understand. And thank you. So, Dr. Rasmus,
Yes.
You are a psychiatrist and also part of the ethics committee.
Right.
So, Dr. Gromesh talked about the AstraZeneca and how it is the one that's designed to go to third world countries. And there are some questions that I have from viewers that sent me that there are some fears and concerns about the ethics behind the vaccines. People are thinking, they're making two different kinds. And I'll have Dr. Radke talk about the difference between the three different vaccines. And how can you ease those people's minds that think, maybe the AstraZeneca is sent to us because it's the one that are going to be doing something more than just vaccine to the Africans, things like that.
Yeah, certainly there is a history in medicine and science that reasonably makes us nervous about what the agenda might be, right? There have been some things that have happened in the past in medicine that would stay with us in our memories about whether or not we can trust the way that things are being handled now. One of the reasons why I mentioned the time that I got to spend at NIH is because I am impressed with how not just the United States, but the world of medicine and science and the companies and universities and scientists throughout all of those different places have learned from those errors, those mistakes, those really unfortunate chapters in our history. Coming out of World War II was the first time that we as a world society wrote regulations about what would or would not be acceptable in medical research. And then we realized that still the specter of racism and assumptions about who should or should not be in charge or in power really still affected the way that those principles were applied. And so we needed to revisit those issues and write stronger standards. And this is not something that we ever rest on. We're always making sure that we update our standards, we reevaluate whether or not agencies, individual scientists, companies, universities are operating ethically. And they all have standards that they need to follow. There are in fact two major oversight boards for every kind of research that we do that would have been involved in the AstraZeneca trial that you had heard about with the vaccine that Beth received, and also from the other vaccine options that will become available to us as the months go forward. Those two agencies are an institutional review board and a data and safety monitoring board. So that first one, an IRB, or institutional review board, would have been part of the experience at Health Partners, where they are not at all related to the researchers themselves. They're an independent group, and their main responsibility is protection. Their job is not at all to review whether or not the science or the vaccine, the medicine, will make anybody any money, will do anything that will bring fame to the researchers. They are all about the safety of the individuals who are in the trial. And that, in fact, includes Beth. She would have counted on their work to make sure that when she signed up for that trial, to volunteer as part of the group of people that help us to know that we can trust this vaccine, she wanted to be able to trust the researchers. And in order to do it, that independent body protected her right from the beginning with all of the science that was planned, without anything looking at the productivity or what money it might make or any agenda that it might have. And then throughout the process of the trial itself, it's monitored by the Data and Safety Monitoring Board. I have the privilege of sitting on one of those still for the National Institutes of Health, and our job is to watch all along the way when a trial is run to make sure that all of the effort, all of the time invested is actually worth it. Worth all of the investment, worth any risk, worth any discomfort, whether it be a little bit of a body ache or whether it be a serious side effect. The job of a board like that is to make sure that the work is being done properly and that people's rights are being protected, people's safety are being protected, all of that to make sure that the science that comes out at the end is trustworthy. It's all a balance, right? In the world where we don't know something about a new disease or a new problem, we can't be sure that things won't go wrong. But what we always need to be sure of is that we are fair to everyone who is involved, and that we make sure that we involve people from all different cultures in each of the studies from the beginning so that they can see the process, they have confidence in it. And AstraZeneca and Pfizer and the other companies like Moderna that are doing this work are all required to bring in individuals from all different walks of life, all different cultures, in order to make sure that the vaccine is safe for all and is not being, how should I say, differentially given to one group versus the other, so that one group would be favored over another or one group would suffer as compared to the other. The equity is critical to the process being fair and safe. And so we count on those agencies to watch over the drug companies in the way that they do their work, watch over researchers, and make sure that everything that they do can be trusted when the results come through.
Thank you, Dr. Rasmus. And yes, prior to those regulations where we didn't have IRB, and now we have people who are independent, like you said, that are just here to oversee and make sure that everybody's rights are protected, and it's done in a very humanly way. And I hope that that can clarify and help people understand that these studies are done in a very ethical way to be fair to everybody. Thank you.
Thank you.
And Dr. Eccles Radke, can you please tell us the difference between the three different vaccines, AstraZeneca, Moderna, and Pfizer?
Sure. So Pfizer and Moderna are the two that have been now approved by the FDA for EUA, which stands for Emergency Use Authorization. Basically, they have, what that means is they have enough data that says it's safe and effective to proceed in a situation like a pandemic and start vaccinating people while they continue to gather data. The Pfizer and Moderna vaccines are very similar to each other in that they use a newer type of technology called mRNA or messenger RNA technology to deliver the vaccine. And I won't get into all the nitty-gritty science details, but basically what that means is what gets injected into your arm is basically a code or a genetic code that stimulates your body to make a protein, not the full virus that COVID is, but a part of it. And then your immune system will see it, and your immune system will start to react to it to create memory cells. So when you actually are exposed to the real virus, you are protected, and that your immune system fights it off and you don't actually get sick from it. So that's how the Pfizer and Moderna vaccines work. Now the difference between those two, people have been mentioning freezers and cold chain. Pfizer, which is the first one that was approved, that is currently being given to healthcare workers around the United States. It's really interesting. It's the first time they've ever had something this severe, but that requires not just a refrigerator, but actually freezers down to negative, I want to say 80 to 94 degrees, dry ice and things like that. So it took a lot of energy and effort and supplies and costs to be able to send those safely, make sure the vaccines stayed, effective and well to get them to hospitals. And the Moderna vaccine, which just got approved on Friday, doesn't require that extreme cold. It just requires, I think, a normal sort of refrigeration process. And so that one will be a lot easier to transport and get around the U.S. and parts of the world. And as Dr. Grummish mentioned, I think the AstraZeneca vaccine works a little bit differently. They use basically an adenovirus, so a different type of viruses as sort of a, I don't quite know how to explain it, a target to carry the COVID proteins into your body to allow your immune system to be stimulated. So when you were to see the actual virus, your body would protect you against it. So that one's a little bit different, and again, doesn't have the extreme cold that the Pfizer one does. As they mentioned, AstraZeneca has not been approved yet. It's still in trial, but all of the initial data is showing that it will be effective, it will be safe. So they need to complete some of that work before they can get approval for it. And I have to say, I'm really proud of those three companies, as well as other ones that are actually working on things like Johnson & Johnson, et cetera. So we have lots of options and lots of access, rather than just one company sort of monopolizing the market. And I really was proud throughout this process. I was nervous at the beginning too. I can see why people are nervous when things get created this quickly. But after studying it, following it, and keeping an eye on things, I'm really, really proud of both how fast but how safe these companies have made things. You know, they stood up partway through this process and said, we're not going to rush things, we're going to make sure it's safe, we're not going to push it just because the government or somebody wants us to push it or throws money at us. And I was really proud of sort of the ethical stance that these different companies have taken in terms of creating the vaccine and doing it right and doing it in a safe manner. And I also got my vaccine. I think it's important to say, you know, if you see people who follow the information and the medical knowledge getting it, you know, hopefully you can trust that it's safe. So I got my vaccine yesterday morning. I feel fine other than a little bit of a sore arm. I felt a little bit warmer than normal today, but not true fevers. I checked my temperature and it was maybe just a tiny bit above normal, so nothing too exciting, but I feel fine. I don't feel sick, and I'm really, really happy that I got it.
Yeah, so thank you so much. And one more question before we move on. People who are watching, if you have any question, please put them on the comment, or there's a phone number that's linked to the screen. Please call if you prefer to talk. So the other question would be, if, for instance, somebody just recovered from COVID, are they required to take the vaccine?
That's a great question. So nobody is obligated, right? This is a personal decision for everyone, and people who have other underlying medical issues or conditions should talk to their doctor first to figure out if it's the best choice for them. What I would say is, for almost everybody, other than select people, the vaccine, you should take it. It's safe, it's effective, and the more people we get vaccinated will really help us with what we call herd immunity, meaning if we can get a bulk of the population vaccinated, the virus has nowhere to go. It needs a host, and it has nowhere to go after that, and so we can really stop the spread. To answer your question, too, if someone has had COVID, can they get the vaccine? At least with the Pfizer data and then Moderna coming out, I don't know the AstraZeneca data yet because it has not been approved, but for the other vaccines, you are able to get it anytime, even after you had COVID. We don't recommend you get it during your acute illness, but once you have been cleared from isolation, you can get vaccinated. One thing we're telling our healthcare workers is that if you've had COVID in the last 90 days, you may consider waiting to get vaccinated. And the reason for that is because right now we only have so many vaccines. More and more are coming in over time. But our goal is to get the people with zero immunity vaccinated first. And if you've had COVID, you likely have some antibodies and immunity to the virus. And so we're asking employees to consider delaying so someone else who is more at risk could get it first. But that said, there's no reason why they couldn't get it when there's plenty of vaccine available.
Thank you. So they have to wait at least 90 days before they can get vaccinated. Dr. Gromish, do you know when the AstraZeneca vaccine would be ready to be sent to?
They are estimating that'll be end of January, maybe early February. They're just a little bit later in the process than Pfizer and Moderna, so that's what the delay is about.
Okay, good. Thank you. And I'm just going to jump different questions that I feel like can go towards any of you guys. Sure. I have the questions here from viewers who sent it to me. One of them I would ask to Dr. Rasmus is that this lady is asking, as a black person, I heard that they are trying to make people in the prisons priority to the vaccines. And she said she's afraid that because the prisons have so many black people, is it because they want to test on those people, like to have guinea pigs like they did in Tuskegee?
You know, this is a good question. It makes sense that you would ask it, again, because of the history of problems that we have had in the past in medicine and research in this country. But I want to assure you that working at a place like Hennepin County Medical Center with Bolo and seeing so many patients we've shared together, many of whom are minority patients, many are persons of color. It is actually heartbreaking for me as a doctor to go through the hospital and see how many people who are not from the dominant culture actually suffering from this disease more rather than less. And so if there are opportunities for protective vaccines and advanced treatments to go to disadvantaged minorities faster, I would be viewing that as an advantage, as a positive thing, rather than a negative one. It certainly makes sense that you would have concerns about prisons in particular, though, because that is a situation where the individuals who are living in that environment already have fewer choices. They've already been restricted in their freedoms, and it may very well seem like there is a requirement, there's a pressure on them in order to participate. This is another place where we in the history of medical science have learned some lessons. We now have special categories in medicine about treating children, pregnant women, and prisoners as categories, individuals whom we think of a little bit more carefully before we move forward with any treatments. So although it may feel in some ways like a rush, like we're moving faster to go into prisons, to give vaccines to inmates and to the staff there, in reality, that's a population that gets more attention to think about safety first and make sure that there isn't an imbalance between the benefit that those individuals might receive and the coercion that they might feel by being offered such a treatment. And so we take that extra seriously in those environments. So I want to let you know that in this situation, just like all of those others that are required of us in science, we've looked carefully, and it makes sense to actually vaccinate folks in prisons more because the ability to isolate, to keep people masked, to stay at the distance that we have the privilege of staying at for this activity that we're in now, those kinds of things are just not an option in the environment of a prison, in those close quarters, where really the worry about a viral spread there is much greater. As great as it is in group living facilities and nursing homes and other places where we're also prioritizing those residents. So the last thing I would say is I'd want you to be reassured that prioritizing folks in prisons is not bias against them, but in fact, it's similar to the prioritization we will have to get people in nursing homes and in group homes and in other places where people live very tightly together, vaccinated as fast as possible to protect them as quickly as possible.
Yes.
It's really the opposite, even though I understand the history of your concern.
Thank you. Yes, that makes total sense because prisons and nursing homes have the highest rate of infections, and there's a lot of worries about the prisons and deaths related to COVID.
Yes.
So thank you. And so Dr. Radke, I know you guys have, like the infectious disease at Hennepin, you have seen it all. And I remember, I think last year you treated one of our patients who had malaria, which is very uncommon here in the US. This is like an African infection. So in Senegal, where I'm from, and Dr. Gromes saw that there is an article on PBS showing that Senegal is leading for control of COVID, which is like, yay. So there are theories saying that, oh, is it, I mean, I know they're doing a very good job with educating and doing social distancing is not that practiced but because of the cohabitation, but people are wearing masks and washing hands and being careful the best way they can. But there are some theories like, is it because Senegalese people or West Africans are so much exposed to malaria that is there any way that they were immune, like they developed immunity that help protect them from COVID because of the immunity from malaria?
That's a great question. You know, there hasn't been any specific data yet to say that someone or a culture or community who have been exposed to malaria are protected. So part of me wishes that were the case, but there hasn't been anything specific study-wise, as far as I know, that shows that correlation. But I have to say, kudos to you in Senegal and everyone there. You're doing better than the United States is, it sounds like, in terms of protecting people.
Yes, thank you. And also in Senegal they use the hydrochloroquine to treat people with COVID. I know it's not recommended here, but they have been using that. And there are some doctors that I talked to that told me it did help. So I don't know what you think about that.
That's a great question. You know, there have been a number of new and old drugs being studied to fight COVID. Everyone is trying to look at different angles of how the virus works on the body and different targets and things like that. Early on, hydroxychloroquine was really touted as potentially being something that could help the immune system and work against the virus. But actually, once studies were done, you know, formally developed, everyone went through the motions to see, it really didn't show that hydroxychloroquine does anything specific to stop COVID or protect people from COVID. One of our researchers here at the University of Minnesota, Dr. David Boulware, did a large study on this too as prevention, and unfortunately didn't find that there was any correlation that it helped. That said, you know, the kind of two main drugs that we've been using, and there are various others in study, some of which have shown some benefit but not much, are one, an antiviral called remdesivir that has some benefit in people who are requiring oxygen but are not sick enough yet that they require the breathing machine in the ICUs. But the other kind of old drug that has really shown some benefit in people are steroids. We know COVID, when it kind of runs rampant in someone's body, for the people who are going to get sicker, it causes a lot of inflammation in their lungs and parts of their body. And interestingly, steroids help quiet down inflammation. So when given at sort of the right time in the disease process, it can really slow down or stop progression of, you know, someone going on to have severe disease. So that has really been sort of probably the thing that I think has shown the most benefit, to be honest, so far in terms of studies.
Okay, thank you for clarifying that for us. And I know that many people don't believe, the extent to which COVID is dangerous and deadly. And Dr. Gromes, I know you're a hospitalist and you work with a lot of COVID patients. Can you tell us, please, about the complications that you've seen or like deaths that may convince people that this is real and,
Right.
before everybody gets vaccinated, we have to keep our social distancing and wear a mask and
Most definitely. Yeah, I see the patients that are sick enough to be admitted to the hospital. So there are a lot of people that do just fine with COVID. But you unfortunately can't always count on being young or healthy and still not getting serious complications. So I have seen patients that do have your kind of comorbidities or underlying illness or disease that may predispose them to doing poorly. So someone that's obese, someone that might have diabetes, heart disease, and they get serious complications of COVID. But I've also seen the patient that is really honestly young and healthy and doesn't have any underlying illnesses. And that's what's a little bit of mystery of this virus is who it attacks and why. The complications that I most often see are certainly the pneumonia. So it's in both lungs. The X-ray is very striking, where you can see it just spread out through both lungs, and really just difficulty with maintaining your oxygen. So really needing a lot of oxygen support. So that's the majority of people is pneumonia. It does get to that really inflamed pneumonia. Your immune system almost overreacts. In some people, where it gets severe enough that it inflames the lungs and they do need to go on mechanical ventilator or breathing machine. So that is unfortunately all too common in our hospital patients. They have very long lengths of stay in the hospital, longer than most a normal pneumonia, and they have very prolonged recovery period. Certainly have patients leave the hospital and still be out of work because of maybe needing still some oxygen at home, or just significant fatigue for months afterwards. And I think there's a lot of comparison with influenza, and we certainly see influenza causing pneumonia too, but certainly not to the degree of COVID. I've never seen a whole floor of influenza patients, and now it's very routine to see multiple floors with COVID patients. Which is just very unusual and obviously means that it's a significant disease, a significant burden in our society.
And how full is your hospital ICUs?
Yes, we actually did have to open up our kind of step-down ICU because our one main ICU, which has 20 beds, was completely full of COVID patients. So patients that needed care for other things needed to go to the step-down unit. So at one point, so in our service for the hospitalist, we care for about 250 patients. 90 of them were COVID, so that's pretty significant. Fortunately, the numbers are going down a little bit right now.
And what did you do to survive and not catch COVID while taking care of all of those patients?
Right. We are very fortunate that we actually test our patients, everybody that's admitted, even if they don't have symptoms. We have a rapid test, so we get test results back within 2 hours. So I know fairly quickly if a patient has COVID or not. Not to say somebody could be very early in the disease and it comes back as a false negative. So we do wear our N95, the masks that we use in the medical field, and then we wear a face shield. We gown, and then we wear gloves, and really the infection rate within staff has been fairly low, fortunately.
And because they are doing what they are supposed to be doing.
Right, exactly.
And Dr. Reckless, can you please talk about Hennepin also, our measures that we are doing to that are protecting staff and other patients that are admitted that don't have COVID?
Yeah, we have similar practices to Methodist Hospital. So early on for our staff, we put in place universal masking. So not just masking when you're around people with a cough or sniffles, because we know the disease can cause a lot of trouble and symptoms, but it also can be spread if you have no symptoms. We know asymptomatic spreaders are out there, and that's the scary thing, is someone who seems well could pass on the disease. So early on, we had all of our staff, no matter in the hospital, the clinics, etc., wearing masks, and very quickly we also implemented universal eye protection. We know that on occasion the virus not only spreads through your nose and your mouth, but your ocular mucosa or your eyes, and so having your eyes protected is as important as your nose and your mouth from getting COVID. And so all of our staff use that at a minimum all the time, and then depending on certain scenarios use the N95 masks as well. In addition to that, we are also doing universal admission screening for every patient who comes in for a surgery for the operating room, everyone who comes in through the psychiatric services, acute psychiatric services, and gets admitted to the psychiatric part of the hospital, etc. So I feel like, even though I know that there's fear to come into the hospital for care and things, and earlier on a lot of people were getting sick and not coming in to seek out care when they probably really needed it, I really can feel confident saying you're okay to come in the hospital if you need care. If there's something not urgent, sure, you can delay, but please come in and get the care you need, because we have really good safety protections for both patients and staff at this point.
Thank you very much. And I know that people are safer in the hospital than at the grocery stores they go to, or the bars. And so that means if somebody is sick and they're having symptoms for heart attack or stroke, they should go to the hospital or to the emergency room, because there are all the safety measures that you doctors talked about that can protect them from getting COVID. So, Dr. Rasmus, I know that you're part of the ethics committee at Hennepin. So, and there at one point where all the hospitals across the country decided that they will decide who will get an ICU bed and who will not, because based on the complications and ability to recover and all of that, and comorbidities. So what do you say about that as somebody from ethics, and just to explain the people the reason why, and then also to remind people that we all have to protect our loved ones. If your grandpa is 84, try to protect them so that the hospital is not going to decide if they need to have a ventilator or not.
Right. Well, this is definitely a global disease, and as we saw it start in other countries before it came to the United States, we all became very fearful that our medical systems would become overwhelmed like they were in places like Italy. And so we, as an ethics committee in our hospital, and a larger group of people who work in ethics throughout our entire state, had meetings very early on to start talking about what if we reach a point where so many people get sick that we don't have enough ICU beds, that we don't have enough doctors and nurses to take care of everyone who is as sick as they might get with this disease. It was something that frightened us a great deal, and so we took that fear and put it toward action to try to start thinking about this early on. I was very impressed with the groups of doctors and also non-medical people who came from our local universities and from our communities. From our religious communities, we had representatives, we had teachers, we had people who work in all walks of life giving us some guidance about what they would hope for priorities, or what they think are the most important things to consider if we reach that level of crisis. So I was impressed with the dialogue, but what I'm really happy to be able to say is that much of what we did for work tended not to be necessary in almost every case in our state. There have been some places occasionally where a small hospital community has been in dire straits because they have had an outbreak locally and have needed to get help, but I have been impressed with Minnesota as a state community getting together to help each other and essentially make it so we didn't have to make those kinds of choices. Mm-hmm. I'm also grateful that the people of Minnesota really have, all in all, banded together and really worked harder and behaved better than many other sectors of American society. So this really is a partnership. It's a partnership between medical people and community leaders you can trust, but also your neighbor. You, the audience yourselves, are the people we count on to be able to trust, to do the work it takes to be able to endure all of the hand washing, all of the masking, all of the extra work that it takes to live your life just to be able to stay safe. Because you have done that, we have actually not needed in Minnesota to do what you would call rationing, having two people in front of you direly sick and saying, I only have one ventilator, I only have one nurse, what will I do? We've been very fortunate that we have not had to do that. But even when I say the word fortunate, I don't want you to hear that word and think lucky, because we have created our own fortune by working hard together on this. And it isn't just the leadership of doctors and really wonderful nurses at the bedside. It is all of us, it's all of you who have made it possible that we have had enough resources to be able to take care for folks. So yes, we have a plan in place. We have some scarce resources in the form of medications now and again, and we do our best to redistribute them around so that all the hospitals will have what they need. But all in all, we haven't actually faced these kinds of ethical crises that we thought we might. And it's because we're in a community that takes care of itself together.
I'm so glad. Yeah, it's a team effort between medical and non-medical and neighbors, like you said, because we can't lay the burden on nurses and doctors and healthcare professionals to take care of the whole COVID, because we have a lot of nurses and doctors who died of COVID, unfortunately, because they have to be exposed, because a lot of people were not caring enough to do what they need to do, and they have so many patients that they couldn't control it and they were exposed.
That's right, Bola. Sometimes it's hard to remember that doctors and nurses themselves are people too.
Yes.
They are passers of the virus. They're catchers of the disease. We think of them as superhuman, almost like they are resources who are there to take care of all of the rest of us.
Sure.
But they are actual human beings too, and it is just as dangerous for them. We're very fortunate, really, that we've been able to work together in this way. So we as healthcare folks are grateful to you in the community for protecting us by what you do. Because if we don't see you in the hospital, that's good news for all of us. Right? Bolo and I don't want to share you as a patient on our hospital floor at Hennepin County. We would rather not see you there.
Yes.
We would be very happy to see you in the community with a mask on and living your life, although difficult, outside of the places where we work. We don't want to see you there, right?
Yes. Yes, that's very true. Thank you. And I mean, Dr. Gromit or Dr. Eccles can answer this. There was a question that asked, if I get a vaccine, how long should I wait before I can hug my little niece and little nephew or any other relative?
I guess I could answer that fairly simply. Caitlin had mentioned that fortunately both vaccines, all of them that we have talked about today, none of them actually have the COVID virus in them. They are all kind of proteins or kind of the messenger RNA that kind of code that codes for the protein. So it's just a part of the virus. So that's the good news, is that you cannot pass this virus on to anyone after a vaccination. So I think that's the remarkable thing, that it is so safe, and it will hopefully support people to get it further, because there is that not possible risk. So, yeah.
Thank you. And one question was that also, when somebody doesn't want to get a vaccine at all, there are some people who are against taking vaccines, and for non-medical reason or contraindication, they just choose because they have other reasons. And some are planning on having doctors write letters for them to exempt them. What would you say to that, any of you?
This is Caitlin. I can comment. So there's not that many actual reasons why someone wouldn't be able to get the vaccine. There are very few, actually. One being, of course, if you get the first one and have a severe reaction to it, we wouldn't want you to take the second one. Or if you have a known severe allergic reaction to components in the vaccines, which someone can talk you through those when you are working with your doctor or a clinic, then you should not get the vaccine. But even in people who have had an allergic reaction to other vaccines, they should do okay, and we are doing some special monitoring and testing of those people ahead of time. And then the other thing that I think is important are people with certain underlying medical conditions. If you've had a condition where your immune system isn't working as well, either because of a disease itself, like say cancer, or a treatment that you get for a rheumatologic disease, a cancer, etc. I take care of a lot of people living with HIV, and even most of those people whose immune systems aren't completely normal can get the vaccine. It's worth a discussion depending on at what point in your treatment you're at with, talking with your doctor about it. But exemptions really, I think, should be pretty few and far between, because this is incredibly safe for people to get. And the other thing, to answer your other question earlier a little bit further too, I think once you get the vaccine, at least the Pfizer one is good about a month after the first shot, the Moderna about 5 weeks or so, AstraZeneca I'm not sure yet, but it's still going to be important moving forward for a while to wear masks, to wash your hands, to social distance. And the reason I say that, even though you may say, well, that doesn't make sense, I got the vaccine, I'm protected, is because, one, other people still may not be protected, and we need to get enough people with what we call herd immunity, meaning, a good percent, 70+% of the population, to be vaccinated. And the other thing we aren't quite sure about yet is, we know the vaccines prevent you from getting severe illness if you are exposed to it. But what we aren't completely sure yet is if you could be asymptomatic and carry a little bit of virus that you were exposed to and pass on to others despite the vaccine. And so I think we're learning more about that. My hope is that that's not an issue, but we just don't know yet. And so at the beginning, for a while, until we get enough people vaccinated, it's going to be really, really, really important for everyone to still mask, to still social distance, to still be safe, until, as a country, as a world, as a population, scientists, governments, etc., can say, okay, it's safe to stop those things.
Thank you very much for all of you for enlightening us. So one more question is that, is there going to be a vaccine against HIV, and is there one for Ebola?
I can try and answer those. So there is one that they've been working on for Ebola that some people have gotten, few people. And then the HIV one, the researchers, interestingly, have been working on HIV vaccines for years. And the problem with the HIV virus is it shifts and mutates and changes a lot. Thankfully, COVID has done a little of that, but not too much, where we've been able to have a steady vaccine target. But the HIV virus is really shifty and tricky, and so we haven't really been able to create a vaccine yet that works. So the most important thing with HIV disease is, one, safe sexual practices, don't share needles if you use needles for diabetes or other things. But also, if you are positive, taking your medication every day and suppressing your virus so you don't spread it to other people, because that's been shown to be effective. So I hope we will get there at some point, but it's been a very hard virus to create a vaccine against, unfortunately.
Yes, absolutely. Thank you so much. I think we are coming to the end of time, and this is a very informative discussion and educational. I'm sure our viewers will appreciate it, and there would be more questions probably on comments, or as people listen or watch the video, they'll be able to get more questions that you guys will be able to answer again. Anything you guys want to add?
I was just thinking about what Caitlin mentioned about the other diseases, and it makes me wonder if some of the audience may be thinking, Bolo, that it seems so fast. We got a vaccine for this virus so quickly. Is that the background of the question that was being asked? Why don't we have one for other diseases that have been around so much longer, right? Yes. And I was surprised by that too, and I'm not the virology expert that Caitlin is, but I spent some time trying to understand the background a bit more, and one of the things that I didn't know is that we actually have a great deal of knowledge about viruses that are in the same family as this coronavirus that causes COVID. And so because of all of that background knowledge, we were much closer to being ready to produce vaccines than maybe I and other people in the public would have thought. So this vaccines, it seems to have come along very, very quickly. And of course there was a great global need, but it's not like there isn't a great global need for treatment for HIV and for other diseases too. So I can see how it might feel like this was so fast. Is this just, or is this ethical? Have the resources gone in the right direction properly? But the one thing that I would say is that I am impressed that we already had a lot of resources moving in the direction of understanding viruses like this one, and we were essentially ready for this to occur scientifically. We needed the will and the resources to move quickly, but we didn't do it by sacrificing ethics, and we didn't do it in a way that we have taken resources away from other illnesses that are very serious and continue to require our attention. And so I was surprised at the speed, but then when I understood that coronavirus is like many other viruses that we already have a great deal of information about, like SARS and MERS, if you remember those diseases, that helped me to understand how we were fortunate enough to get multiple companies really coming up with treatments that are helping us. And so that was something I wanted to mention, because I think that's in the background of the question too. How did we get here so fast? We're also fortunate that government was willing to put a lot of money into getting all of the production lines up and running quickly too. As soon as we got data, then we didn't have to wait to raise a lot of money in order to make the vaccine. The money was available and ready from governments. And so I think we're fortunate that way too, that we got a great deal of support from government to do this quickly.
Yeah.
It does make me ask, why haven't we been as assertive with other diseases like HIV? And I think the answer is we should be. I hope that we learn a lesson from that here too.
Right.
So I didn't want to take all that time, but it was one of the things I thought of.
And also I think the HIV also affects the T cells, which are part of our immune system, and if we have vaccines that suppress them, maybe that's a big problem. Dr. Eccles?
Yeah, that's right.
Sorry, could you repeat the question? Some of it I cut out.
No, my comment was that maybe the difference between having vaccine for HIV, I mean, like we have for COVID, it's because HIV, the T cells are the ones that are involved, and we can't suppress those.
Yeah, I think it's just a different virus. It works and attacks cells and different types of cells in a different way, and shifts and mutates and things like that. So that's why they've had a lot of trouble actually figuring out where they could use a vaccine to stop it from getting into cells, replicating, etc. And I think the other comment, I thought Dr. Rasmus's comment was really important and really, really good about sort of the manufacturing and this pace and all of that, and that they didn't sacrifice safety, but thankfully we had the funding from the government and the resources to move things along quickly. And the other key thing I think that's really important to note here, you know, at least at Hennepin, we see so many minority populations, immigrant populations, refugees, people from sort of all over the world. And we have really seen, heartbreakingly, a number of higher rates of illness, death, etc. in Latino families, African-born families, people from all over the world, partly because of their family structures, partly because a lot of people from other places are essential workers and can't stay home and can't social distance. And it's just been a tragedy for so many of these underserved communities and different populations. And so what I really just want to reinforce here is how important we think it is that you all should get the vaccine. You should talk to your doctor about it, because we want to protect you. People aren't here to experiment on you, although I understand the concerns and everything that has been said throughout this, because we just are fearful from what we've seen already, in that certain patient populations are at much higher risk for disease and critical illness and even death. So, you know, please make sure there's so many myths and questions out there that you're asking medical professionals. What are the truths? What should I know? How can I tell others what's important, and going from there?
Yes, and you guys at Hennepin are doing a very good job with Patients who are newly diagnosed with HIV, they get directly connected to the positive care clinic that takes care of that, and they get medications for free. If they can't afford them, they get help. And so don't be afraid to come forward. There is help. And also about the vaccines, I know that my grandma had so many kids. Her and her mom and her great-grandma, they had so many kids, but all of the kids died except maybe 2 or 3 at the end. Why? Because of infectious diseases, polio and many others. And those were eradicated by the time they were born. And why? Because of vaccine. So I know vaccine works. That's why some of the diseases were eradicated in Africa. And whoever doesn't believe that it can work, I know my grandma does, because she's lived it and she's seen it. And that's why I will take my vaccine on Monday, and I highly encourage anybody who's not contraindicated to do it. And once again, I'm very pleased and honored to have all of you here. Dr. Gromes, thank you so much.
Yeah, thank you.
Dr. Rasmus, thank you so much. This time I'll get it right. Dr. Eccles Radke, thank you so much. And also, each one of you will have Bolo's Body Butter Cream of your choice to take home. And Dr. Eccles Radke, I will bring yours to work for you. And everybody, please, if you are interested in Bolo's Body Butter, just know that our proceed will go towards Chalal Africa to help women and children's health in Africa. Thank you so much. And I'm sure you guys will come back here another time, because it's great to have you, and I'm sure the viewers will love it. Thank you and have a good night.
Thank you.
My whole life, my father told me stories about moving to the United States. He would tell me that his brother, my Uncle George, was already living here and let my father stay with him for a while. Through my Uncle George, my father was introduced to our cultural organization here in America, who helped him make connections, apply for college, find his first job, and adjust to life in a completely different culture than he was used to. The Cultural Association helped him get started on his new life. My Uncle George would bring my father with him to the annual Summer Cultural Groups Festival, and later, he would bring me. It was incredible to see so many people of all ages laughing and celebrating with food and song and dance. It brought back the best feelings of home and gave my father the opportunity to pass his culture, language, and values on to me. My father and Uncle George were very close, so when George died last year, my father wanted to honor his wishes to be buried with a traditional ceremony back at his birthplace. My father told me that because Uncle George had cultural group life insurance, he was able to afford to bring George home and have the traditional burial George wanted. Though my father had been able to honor my Uncle George's wishes, it got me thinking about my own family. One day, I'd have to make the same arrangements for my own parents, and my wife's parents as well. Of course, we would want to bring them home and honor their wishes, but it would be a financial hardship for our family. There were a lot of things to think about, even though I really didn't want to think about them at all. When my father told me about cultural group life insurance, he told me it's intended to help families when they need it the most. It's not tied to an employer, so no matter where my career takes me, I'll always have coverage. The more people who participate and the younger they are, the more it helps keep the insurance premiums down for the entire association. Because my parents have cultural group term life insurance, there will be money available to help me provide the kind of service I want to give my parents. And by joining, I can put my mind at ease and continue to celebrate our traditions into the future. With cultural group life insurance, I can worry less and spend more of my time celebrating with the people who matter most to me.